Pancreatic disease, which includes pancreatitis, is one of the more frequent GI causes for hospital admissions. To provide us an update on advances in pancreatic diseases, it's a pleasure to welcome to the podium Dr. Tim Donahue. Dr. Donahue is an assistant professor of surgery at UCLA, and he is the chief of GI and pancreatic surgery.
All right, well, thank you for asking me to come speak today. As was introduced, I am the chief of GI and pancreas surgery at UCLA. My perspective on what's new in pancreatic disorders is obviously going to be from a surgeon's standpoint. It's a very broad category, so I've highlighted the new stuff that's going on in most all pancreatic disorders, and we'll also cover the pertinent background information to understand what's new. Fortunately, there is some new stuff. The general concepts and topics that we'll cover are acute pancreatitis, chronic pancreatitis, pancreatic cysts, pancreatic cancer, and pancreatic neuroendocrine tumors. Acute pancreatitis first. Acute pancreatitis, very common condition, very common problem in the United States. The most common cause is gallstones, and second is alcoholism. As a surgeon, we mainly see the cases that are gone very bad with severe acute necrotizing pancreatitis. The new stuff in treatment of acute pancreatitis really was published in 2010 in this New England Journal of Medicine article, which has changed the treatment of patients with severe acute pancreatitis. So this is for severe acute necrotizing pancreatitis. The old treatment paradigm was for these patients to undergo relatively early surgery, urgent surgery after they are admitted to the hospital for debridement and drainage. But the approach has changed to a more conservative approach with surgery in a delayed fashion. Rather, patients should be first approached with treatment of their end organ insufficiencies before an operation is undertaken, if at all. This article here, a step-up approach or open necrosectomy for necrotizing pancreatitis, really highlighted this new paradigm shift and showed it in a randomized controlled trial. If you have patients who develop severe acute necrotizing pancreatitis, it would be ideal that they be referred to a specialty center, but if they are in the hospital, the best approach for them is to place a percutaneous drain and have their end organ abnormalities treated first. There are many patients who can undergo just percutaneous drainage who do not need to undergo surgical debridement. Now, because of this paradigm shift in terms of the stepping up, what they're talking about, the step up means the first step is a percutaneous drain, the second step may be another percutaneous drain, the third step may be an eventual operation. I caution you that surgery still is a part of the treatment of these patients. It is important for some in terms of hastening their recovery, as this disease can take a very long time for recovery. But it should be reserved after the patient is stabilized elsewhere. So in this study, they looked at 90 patients. Patients either underwent an early necrosectomy or percutaneous drainage, and then a minimally invasive necrosectomy, laparoscopic necrosectomy, or a retroperitoneal approach. And basically, they found that a third, I think this is probably an underestimation, a third were able to get through with just a percutaneous drain approach alone, didn't need to undergo an operation. And the folks who had the step-up approach rather than early surgery had less multisystem organ failure. The mortality was about the same, and obviously lower hernias and whatnot. So we really adhere to this new treatment paradigm, as do most centers who treat a lot of patients with necrotizing pancreatitis. So if you have a patient who is hospitalized with necrotizing pancreatitis, severe necrotizing pancreatitis, tell the surgeons, like myself, to hold off just a little bit and treat them with percutaneous drain first. So as I said, this was published in 2010. Since 2010, unfortunately, there's been nothing much that's come out new about acute pancreatitis or the management of acute necrotizing pancreatitis. But the good thing is compared to 10, 20 years ago, the mortality rates are much, much better. And I think that those are multifactorial, but one of the main associations is that we are taking a more delayed approach to aggressive treatments of these patients. Very rarely, if ever, do we see the big debridements that used to occur with open abdomens, packed in the intensive care unit. Rather, it's much more less aggressive, shall I call it, barbaric approach. Okay, the next topic that we'll cover is chronic pancreatitis. And so just to first review chronic pancreatitis, it's an inflammatory disease of the pancreas. It's marked histopathologically by fibrosis of the pancreas, which leads to eventual loss of exocrine function and endocrine function. It's important to know that chronic pancreatitis is permanent and irreversible. Acute pancreatitis, by definition, is something that can be reversed. So there's acute intermittent pancreatitis, which is reversible, and patients can have multiple acute episodes. But once they convert to chronic pancreatitis, it is irreversible. It is a permanent change. Most patients with chronic pancreatitis have severe pain syndromes, and so the treatment goals are really primarily pain control and also other measures that can be done and used to slow and inhibit the disease progression. Etiologies for chronic pancreatitis are many. By far and away, the most common etiology in the United States is alcoholism. Other ones listed here are genetic causes, right? So genetic familial chronic pancreatitis is very important to identify. The most common gene mutations are the PRSS1 and SPINK1 mutations, which are both genes involved in trypsinogen or trypsin synthesis, and then CFTR, cystic fibrosis related gene. It's important for these patients to be screened and identified, especially if there's familial chronic pancreatitis, because they are at, over their lifetime, a 40 times increased risk of developing pancreatic cancer, which we'll discuss in a little later. Autoimmune pancreatitis and then other obstructive causes of chronic pancreatitis. Pancreas divisum, which is a cause of chronic pancreatitis, deserves special mention because I'm sure many of you in the audience have seen patients who have nonspecific abdominal symptoms, nonspecific abdominal pain, undergo a CT scan or an MRI, and it says that there's a pancreas divisum that's present. The first important point to know about pancreas divisum is that it is present in 7% of patients on autopsy studies. A large majority of these patients are asymptomatic, and the pancreas divisum never causes any discomfort or pain. So patients who have pancreas divisum, who have nonspecific abdominal pain, get a radiology study, and incidentally have pancreas divisum identified. I caution the use of endoscopic sphincterotomy of the minor papilla and/or surgical sphincteroplasty, which is very rarely ever done anymore because of the fact that there are many patients with asymptomatic pancreas divisum. Rather, we prefer, and most in the pancreas community prefer, to intervene on patients with pancreas divisum with the nonspecific abdominal pain only if they have other evidence or manifestations of some form of chronic pancreatitis and/or ductal abnormality. So if a patient has these abdominal symptoms, is found to have a pancreas divisum, and say has a dilated pancreatic duct, well, there's evidence that there's hypertension in that duct, potentially because of the divisum, and they are much more likely to benefit from the sphincterotomy or sphincteroplasty, which is very rarely ever done. And then there are other patients who develop chronic pancreatitis and really focus on the management of their chronic pancreatitis, either medically or surgically, in addition to the divisum. So have a bit of a high threshold to intervene on patients with pancreas divisum unless they have other evidence or abnormalities within their pancreas, because even if they do have these nonspecific abdominal complaints, it's usually unlikely that it's due to the divisum, or they will derive little benefit from a sphincterotomy endoscopically. Many folks have looked into this. Okay, other pertinent points about the medical management of chronic pancreatitis. What about pancreatic enzyme replacement? So many patients are on pancreatic enzyme replacements. I would recommend that only patients who have evidence of pancreatic exocrine insufficiency manifest by steatorrhea or fecal fat content or oil in the toilet, be placed on pancreatic enzyme replacement. If you're going to put a patient on pancreatic enzyme replacement, make sure that they get 30,000 international units of lipase with every meal. So different types of replacement therapies have different levels of lipase. The goal is 30,000 units of lipase. Of course, Creon has like 24,000 units of lipase per pill, so it requires 2 pills per meal, about 30,000 units. And it's also important to give an acid-reducing medication with these because they're not well enterically coated. So they're less effective if not given without an acid-reducing medication. The theory, so many patients who I see are on pancreatic enzyme replacements, who have chronic pancreatitis are on pancreatic enzyme replacements for the purpose of reducing their pain or acute attacks. We do not support or endorse this treatment, and many in the pancreas community also don't, and I'm going to go through the reasons why. Well, the rationale to do it is that if you put a patient on pancreatic enzyme replacements, it's in theory inhibits the CCK release, which is a stimulant of the pancreas, so this pancreas is less stimulated. There have been many studies, which I've listed here, that have shown no consistent benefit in terms of reducing pain for patients with chronic pancreatitis who are routinely placed on pancreatic enzyme replacement. So reserve it for folks who have evidence of exocrine insufficiency, which they're eventually going to get with their chronic pancreatitis. The American Pancreatic Association put out a statement in 2011, there is insufficient evidence to support a trial pancreatic enzyme therapy for pain. In parallel with this, octreotide, another agent which has been shown, which shuts down the pancreas essentially, has also been tried for patients with chronic pancreatitis to reduce or minimize their pain. 4 randomized trials, no consistent benefit. So shutting down the pancreas essentially in patients with chronic pancreatitis, not so great. Other things that patients with chronic pancreatitis can develop are the main duct strictures or stones. You may see these patients, and the alternatives are endotherapy versus surgical therapy. Again, most of this should probably be managed in a high-volume pancreas center, but the bottom line here is endotherapy does have some efficacy, but this study out of the Netherlands here shows that surgical therapy is much more durable. I think it is appropriate or okay for patients to be referred to a gastroenterologist for an attempt of endotherapy if they develop a pancreatic duct stricture or pancreatic duct stone for an initial attempt, particularly stricture, maybe not stones. Stones much better with surgery. For an initial attempt to fix that, but don't linger. If the patient if the stricture is not better or if their stones are not cleared, I ask or we recommend that you have a low threshold for surgical intervention based off this well-randomized controlled trial, as the Dutch usually do. Total pancreatectomy, autoislet transplantation. This is another new treatment in chronic pancreatitis. It's really finding its role in the treatment for chronic pancreatitis, but it's new, so I'm going to address it. It's really for folks with small duct disease. So if a patient with chronic pancreatitis doesn't have dilatation of their main pancreatic duct, there are a few endo or surgical therapies that can help them, but patients who have severe debilitating pain with perhaps endocrine, exocrine insufficiency, who do not have a dilated main pancreatic duct, this is really the best treatment for them, or one of the treatments for them. There's debate about that. Relative contraindications to it, so what do? We take out the pancreas, the islets are then harvested and they are injected into the portal vein of patients where they find their way to the liver and reside, which is a friendly environment, ecosystem for them. So patients with relative contraindications, pre-existing diabetes, prior pancreatic surgery, and then issues with the liver because those are where the islets are going to go. But I just want to show you some of the outcomes of patients who undergo total pancreatectomy and autoislet transplantation. Some of this data in here is what we have generated at UCLA. It was a multi-institution analysis. This just shows that the islet yield is lower in patients who underwent previous pancreatic surgery, so there's a relative contraindication there. But this is some of the good stuff, right? So you can see on the left side these are insulin requirements, the patient's preoperative insulin requirement, and then the time of discharge is the second column there. But it does go up after the pancreas was removed, but it's pretty durable. The insulin requirements don't seem to change, and this has followed patients for 120 months or 84 months or so. So the cells that do land in the liver seem to like it and do a good job. And that's paralleled by the C-peptide levels, where you can see that it decreases from preoperative to discharge, but again stays relatively steady over time. So it can be easier to manage these patients as they will obviously have no glucagon and develop brittle diabetes. Narcotic requirements, another good outcome from this treatment. You can see the narcotic requirements from preoperative to discharge to months after, and this follows about 84 to 120 months, and the narcotic requirements do significantly decrease too. So an effective treatment for pain for patients with chronic pancreatitis. So chronic pancreatitis, in summary, it's a histopathologically irreversible condition. The most common indication for an intervention is pain. A lot of these patients have pain syndromes. Hereditary chronic pancreatitis, 40% lifetime risk of developing pancreatic cancer. These patients should be placed into screening protocols, screening studies, which are being performed. Pancreatic duct stones, if you get a CT scan and you see calcifications within the pancreas, those are by definition pancreatic duct stones, and they are pathognomonic for chronic pancreatitis. Whenever an intervention is planned, it's important to rule out pancreatic cancer before anything is done. Endotherapy, we talked about for strictures and stones, variable efficacy. It is a good place to start, but surgery does have a role here too. Skipping down, total pancreatectomy, autoislet transplantation, as I showed you, is finding its way in the treatment of this disease, and it has folks have durable pain relief and better insulin requirements. Okay, pancreatic cysts, next on the agenda. This is a beast of a topic and generates a lot of excitement, controversy, enthusiasm amongst folks who treat pancreatic disorders, primarily because they keep changing the guidelines on how to manage them. There are a number, the Sendai criteria, the Fuqua criteria, the AGA just last week or 2 weeks, maybe last month, just released a statement on how to manage pancreatic cysts. So I guess for the most part, nobody really knows what the heck's going on, but the guidelines keep seeming to change. So at least it's a source for a number of publications which we have participated in. Anyways, the reason why they're such a big topic is because they're really prevalent. They're really prevalent. I put here that the prevalence is 5%, but it's more like 15% in older folks. So this has been shown on autopsy studies and incidentally found cysts on CT or MRI. It's thought that at least 10 to 15% of the population has a pancreatic cyst. CTs, MRIs are being done much more frequently, and so they're being discovered much more frequently. Okay, what are the different types of pancreatic cysts? You can see on the left there, those are essentially benign cysts, inflammatory cysts, pseudocysts, like in patients who have had an episode of severe acute pancreatitis. Moving to the right, as you can see on the bottom, with increasing malignant potential, there's then the neoplastic cysts, serous cyst adenomas. Those are 99.999999% of the time benign. Then there's the mucinous cysts. So mucinous cysts is an umbrella category, includes mucinous cystic neoplasms, a little bit of a confusing nomenclature there. Also IPMNs, intraductal papillary mucinous neoplasms, et cetera. And then on the right there is obviously the highest malignant potential, or the ones that already are malignant in terms of cystic degeneration of tumors. The main goal in cyst management of patients is to differentiate mucinous from non-mucinous cysts, right? Because those mucinous cysts are the premalignant conditions. They're not the most common premalignant condition of the pancreas. The main precursor lesion to pancreatic cancer are PANINs, pancreatic intraepithelial neoplasias. Those are the guys that are akin to the colon polyps, but cysts are neoplastic and can develop into cancers. Here's some images of what characteristic cysts look like. This is a serous cystic neoplasm or a serous cyst adenoma. There's usually a bunch of microcysts. You can see the septae between them. They characteristically describe it as a honeycomb appearance, and there may be a central calcification. This is a mucinous cystic neoplasm in the tail of the pancreas. I've put a table in the slides there just that summarizes the different cysts. It's a unilacular cyst. It mainly occurs in the body and the tail of the pancreas. It really exclusively, for the most part, occurs in women. It's usually middle-aged women that develop it. And it's kind of got a neat a theory as to why they develop. Histopathologically, these have an ovarian stroma surrounding the cyst epithelium. They stain for estrogen receptor, progesterone receptor, HCG positive. How the heck does ovarian stroma get into the pancreas? It's thought that they develop because during development there's an ovarian rest that's left in the pancreas. Ovary apparently develops in the upper abdomen and migrates down to the pelvis, and on its way it drops off a couple of cells that eventually turn into mucinous cystic neoplasm. These intraductal papillary mucinous neoplasms, they're very common, IPMNs. This one shows a main duct IPMN where the main duct of the pancreas is dilated, or the branch duct type where just a branch duct and the main duct is not dilated. So IPMNs are, by definition, a defect of the ductal system of the pancreas. And then there's these other rare birds, the solid pseudopapillary epithelial neoplasms, again, most commonly occur in females. They have relatively little malignant potential. We have seen some patients with metastatic spens, but they are resected because they can grow really large and wreak havoc, invade into organs and blood vessels and other stuff like that. So the treatment is resection. Anyways, I've listed the different cysts that are located, the different cysts of the pancreas that develop here in terms of their gender predilection, their age, et cetera, et cetera. For the most part, mucinous cystic neoplasms, spens are resected. Serous cysts are not resected unless they cause obstructive symptoms. Pseudocysts, complex management, and then the IPMNs are a controversial subject. So as I said, which we'll discuss in a little bit, the main objective, if you have a patient who develops or has an incidentally identified cyst within their pancreas, the main objective is to distinguish mucinous from non-mucinous cysts. Our diagnostic accuracy of that or distinction of that is not that great. They have characteristic imaging findings, which you can see, but that's usually backed up by an endoscopic ultrasound and sampling of the cyst fluid. Here is the landmark study out of Bill Brugge's group from Mass General, where they looked at different cyst fluid markers obtained on endoscopic ultrasound to distinguish the mucinous versus non-mucinous cysts. And there's carcinoembryonic antigen was the best one. And you can see on the left there's malignant mucinous, benign mucinous versus inflammatory and serous, and the CEA is much higher in the mucinous versus the non-mucinous cysts. It does not distinguish malignant from benign mucinous cysts. CEA is a marker of mucinous cysts, which need to be paid more attention to, potentially surgically resected, certainly surveilled, but it does not accurately distinguish malignant mucinous from benign mucinous cysts. Here is the receiver-operator curve where they determine the optimal level of cyst fluid CEA, and the answer is about 192. Which yields about an 80% accuracy. So cyst fluid greater than CEA greater than 192 to an 80% accuracy is suggestive of a mucinous cyst, not malignancy. Here are the most adhered to guidelines on how to manage patients with mucinous cysts of their pancreas. It's out of Sendai, Japan. These are the old guidelines in 2006. You can see we'll go over them, but they look relatively simple. Everyone was relatively happy with them, and then they went ahead and screwed them up in 2012 and made them way more complicated. Criteria for resection before 2012 were if the main duct is enlarged, it should be removed because there's a high risk of malignancy. Mural nodule or solid component on the cyst seen on MRI, CT scan, or endoscopic ultrasound, or if it's greater than 3 centimeters in size. However, the key changes in 2012 now where they suggest that cysts greater than 3 centimeters can be observed, and that they only recommend endoscopic ultrasound for cysts that are greater than 2 centimeters. The Japanese, where these were developed, although there were a bunch of American surgeons and friends of mine who were involved, and I give them a hard time about this all the time, but they don't use endoscopic ultrasound as much as we do. Well, anyways, we became very concerned about these changes in cyst management, so we looked at our own series of resected side branch IPMNs, which were 150 at UCLA, and we, using the receiver operator curve sensitivity and specificity, found that the optimal size cutoff to recommend surgical resection to identify those with high-grade dysplasia or cancer was 2 to 2.5 centimeters. So the trend is to increase the size of the cyst for resection, and we found that it was actually even a little bit smaller than before. So I think, obviously, with the new criteria, the specificity for high-grade dysplasia or malignancy are getting better, but it's at a cost of a sensitivity. And we're talking about pancreas cancer here, so once that develops, I should say the cat is for the most part out of the bag. We also challenged that endoscopic ultrasound cutoff of 2 centimeters, and you can see we identified 4 cysts that were resected in our series because an EUS that were less than 2 centimeters because the EUS saw something that the CT or MRI didn't, and those 4 patients had high-grade dysplasia or cancer. So again, the increased specificity really comes at a cost of sensitivity. Okay, pancreatic cancer. This is a topic that's near and dear to my heart. I'm a pancreatic surgeon, usually do about 2 or 3 pancreas surgeries per week. I also have a molecular genetics lab in pancreatic cancer that's funded by the NIH and NCI. But we'll talk about pancreas cancer. It's a big problem. It's currently the number 4 cause of new cancer deaths in the United States in 2014 in both men and women. Number 4 cause. The incidence of pancreatic cancer is on the rise. The survival of patients with pancreatic cancer ain't improving too much. So if the current trends continue with all cancers, by 2020, pancreatic cancer is predicted to become the number 2 cause of cancer-related deaths in the United States. I don't know if we'll get there by 2020, but it's certainly on route if the trends continue. It will overtake breast and colorectal cancer and be number 2 to lung cancer. Big disease burden in this country. One group of patients where we have made some progress in pancreas cancer, I just want to show you, are those with what we call borderline resectable or locally advanced tumors. Before surgery or at the time of diagnosis, pancreas cancer is really best categorized by this staging system: potentially resectable, borderline resectable, locally advanced, or metastatic. Potentially resectable are small tumors confined to the pancreas. Metastatic is distant spread. The other 2 categories is everything in between. Until about 10, maybe 15 years ago or so, the treatment for potentially resectable patients was surgery and then chemotherapy, and then was chemotherapy for everybody else. But now, now surgery has found its place into this borderline resectable, locally advanced group of patients. We take a particular interest in this group of patients as surgeons because I think that what we have found and shown is that we can really help them, and this is where the majority of progress has been made in these patients. Not any new therapies. The chemotherapies are getting a little bit better, but our combination of marriage between chemotherapy and surgery has really helped these folks. So rather than take these patients with borderline resectable or locally advanced tumors, just meaning that they involve the local vasculature, right to surgery, we rather treat them with chemotherapy or radiation therapy first, and then we take them to surgery. Most of our peer institutions, MD Anderson, Memorial Sloan Kettering, treat these folks for about 3 months or so with chemotherapy and radiation. We rather wait at least 6 months or longer to take them to surgery. We think that this longer duration of preoperative therapy better selects for patients who will benefit from a local operation, a surgery or a local therapy. I always tell my patients the rationale for doing it is if we take them to surgery and then they put them through a huge intensive operation and then they develop a liver metastasis 6-9 months later, that I didn't do them any good and that we did wrong. So essentially, this is what I'm describing here. Here's a locally advanced tumor. You can see it circled. It involves a portal vein, superior mesenteric vein. This patient got 9 months of this very aggressive FOLFIRINOX therapy. It's FOLFOX and FOLFIRI for colon cancer, just put together, all three drugs. And afterwards, you can see the tumor shrank, took the patient to surgery, resected their portal vein, superior mesenteric vein, put it back together, and he did very well and is still alive. But this is, in a nutshell, what I'm talking about and how we approach these patients with these big tumors that involve the local vasculature. As I said, we first started this in the 1990s, but we've been doing a heck of a lot more of it recently in the last 4 years. About 80 to 90% of patients who we think are good candidates for surgery, who we take to the operating room, we're eventually able to resect at the time of surgery. So our selection criteria for those folks is good. And as I told you, we treat them for a little longer. The median duration of therapy is 6 months in the last series, and most of our peer institutions are 3 to 6 months. Anyways, we're taking out veins, we're putting them back together again, which is okay. Can't take out the SMA. Celiac axis is a little bit more difficult and controversial. But anyways, the bottom line is I want to show you that our survival median for this group of patients over the last 4 years has been 48.9 months, and the median hasn't even been reached. 4 years. And if we superimpose what our survival is, this is UCLA data too, of our early stage patients, 1A, 1B patients, those small potentially resectable tumors, 45 and 36 months, it's as good, if not even a little bit better. So I think that our approach to these patients is correct, which involves a longer duration of therapy. Yeah, we're not going to operate on as many folks, but I think we're identifying the patients who do benefit from an operation. And that's usually about, at the time from diagnosis to therapy, about 60% of patients with borderline resectable disease at diagnosis make it to surgery, and about 20 to 25% of those who are locally advanced. Okay, pancreatic neuroendocrine tumors in the last 10 minutes here. Those are the other tumors of the pancreas, right? They develop from the endocrine compartment or the islet cells, and they're a problem too. They are increasing in incidence over the last 20 years, so a twofold increase in incidence, probably because more of them are being detected on CT and MRI. They were in popular press recently or in the last few years because this is what Steve Jobs had, and he really had every innovative novel treatment possible and obviously still succumbed to his disease. Pancreatic neuroendocrine tumors are really divided into two categories. There's functional and non-functional types, and that's really just defined by whether or not there are symptoms present. The non-functional ones are the more common ones. That's 40 to 90% of them, and they're the ones that are usually seen. Okay. There are a number of staging, grading, classification systems for neuroendocrine tumors, which means that not one of them is that great, right? So there's the WHO, AJCC, the European community has a staging or grading scheme. But basically, you can see that the disease progresses from a well-differentiated neuroendocrine tumor down to a poorly differentiated neuroendocrine carcinoma. These look a lot like small cell oat cell cancers of the lung and behave very similarly. WHO likes grades, so all they do is look at the Ki-67 index, don't look at lymph nodes or anything else for the most part, and that's how they determine the biology of these tumors. AJCC looks at tumor size and nodal status like it does to every other tumor. Anyways, you get bigger tumors, more nodes, you get a higher grade, and they put you down in the neuroendocrine carcinoma category. NCCN, National Comprehensive Cancer Network, treatment recommendations for these patients are essentially all of them, even small or larger ones, go to resection. This has been challenged, and I'm going to show you some of the ways that I've challenged it. Patients with metastatic disease, for the most part, are given systemic therapy. So the NCCN, as I said, recommends that all patients with neuroendocrine tumors that are resectable go to surgery. And the question that I ask is, do all these really need to be surgically resected? This is what I'm trying to get at. This is a patient of mine who's an 81-year-old male who has a 1 centimeter non-functional neuroendocrine tumor in the tail of the pancreas. Does this patient need to undergo a surgical resection, or can they be surveilled? Well, the bottom line is, I don't really know, but I've got all the information put together to have a very well-informed philosophical discussion with the patient. So do all non-functional neuroendocrine tumors need to be resected? Yes. The argument yes is because surgery is curative for the most part in greater than 50% of cases. There's no randomized trial examining surgery versus observation, no preoperative measurable tumor characteristic that approximates the biology. So we can't really stratify these patients into how aggressive their tumors are before surgery. The argument no is most are indolent and are low grade and will never be a problem. Will this tumor kill this 81-year-old gentleman? Probably not. And as I said, autopsy studies have shown that there's about a 10% incidence of incidental neuroendocrine tumors, so they're more common than thought. So the prognostic variables, as I said, the WHO just really looks at grade Ki-67 index. This is a summary of multiple studies that have been done, and these are the univariate characteristics correlated with survival, and I've highlighted here where all the ones that include grade. So grade is actually good. Grade is good. So can we identify the grade of this tumor in this 81-year-old to better stratify whether or not they need resection or not? We'll discuss that. How about size? Size is another thing that we can measure preoperatively. Should we remove all those that are greater than 2 centimeters? Should we remove all those that are greater than 1 centimeter? If you have a patient who has a CT MRI and there's a small neuroendocrine tumor identified that's 1 centimeter or so, can we safely watch it? What about a 3 centimeter tumor? So can we use size? Does size approximate the prognosis of these patients? So the next question, or a more refined question, is should tumor grade, size, or a combination thereof be used to identify patients who can safely undergo observation, that 81-year-old? So can grade be used preoperatively? As I said, the rationale is it's the strongest survival correlate in most studies. The problem with grade is that we can't accurately assess it preoperatively. So the way to do that would be to biopsy the tumor, either with fine needle aspiration or a core needle biopsy percutaneously or via an endoscopic ultrasound. And there have been no studies to show that that can happen. Our pathologists are extremely skeptical that you can get an accurate assessment of the grade of the tumor via this measure, because the WHO defines the grade of the tumor as the highest hotspot in the tumor, the highest Ki-67 hotspot. So there surely will be sampling error with this mechanism. Okay, how about the size? Size. Can small tumors be observed, right? So this is, let me go back. This is a bunch of studies that have been done, and I want to just focus on the Mayo Clinic one. An argument that yes, the small tumors can be observed is that they had a series where 77 patients with 1 centimeter median-sized tumor were followed for 4 years, no disease progression. No disease progression. So none of them got bigger, none of them progressed, none of these patients had to go to surgery. No, an argument for no is the Mass General study where they took, in the tumors that they took out that were less than or equal to 2 centimeters, 3 of the 39 patients developed liver metastases. So there was systemic disease in these smaller patients. Or the Northwestern study where they showed that 3 of 56 tumors less than 2 centimeters had liver metastases. So even though they were small, they still had an aggressive biology. So in summary, on neuroendocrine tumors, can EUS, fine needle aspiration, core needle biopsy be used to assess the grade of the tumor to help stratify which patients need an operation? The answer is probably no. The test accuracy hasn't been validated. Our pathologists and I'm skeptical that this will happen because it's really defined as the hot spot in the tumor, and it's subject to sampling error. How about the small ones? This 81-year-old gentleman with a small neuroendocrine tumor, 1 centimeter, should that undergo resection, or can it be observed? And the Mayo Clinic says no disease progression over 4 years, so that they would argue that potentially yes. But the other studies that I listed here, if you put them all together, that the conversation or the informed discussion with the patient and involved in the decision-making is neuroendocrine tumors less than 2 centimeters, that's mainly the cutoff that's been used, have about a 5 or 10, more like 10% chance of harboring some other aggressive biological feature associated with them, whether that be high-grade or nodal metastases. So that's the chance. That's the risk that's taken that we know from those that have been resected. So it's a conversation and discussion that I have with a patient is that if we can observe the tumors less than 2 centimeters, and I'm comfortable doing so, but there's a 10% chance that there's something else that's going on in that tumor. And that's the best that we can answer that question right now. So I'd like to thank you again for inviting me to come speak. In summary, acute pancreatitis, not much going on. Step-up approach, start with percutaneous drainage, work your way up to surgery if necessary. Chronic pancreatitis, enzyme replacement really just for patients with enzyme insufficiency, not to shut down the pancreas. Have a high threshold to intervene on patients with pancreas divisum. Total pancreatectomy, autoislet transplantation is finding its place in the treatment of this disease, best suited for patients with small duct disease. Pancreatic cysts, the classifications criteria keep changing. Just refer the patients to a high-volume pancreas center so we can fight about it every Tuesday morning like we do. But the trend at this point is to of the criteria are essentially less surveillance, less surgery, and that is coming at a cost of decreased sensitivity, but better specificity for high-grade dysplasia or invasive cancer. Pancreatic cancer, the treatments are improving. Its prevalence its cause of cancer-related deaths, its place in the list is increasing. The patients with locally advanced and borderline resectable disease there are great advances in terms of the combination of therapies that are being given in surgery and medical oncology. So very happy to see that, very proud of that. Pancreatic neuroendocrine tumors, again, another crap shot here about how to manage these folks. Small tumors potentially can be observed, but there's about a 10% risk that they harbor some other high-grade biology associated with them. So again, thank you very much.
Questions for Dr. Donahue? Let us get your microphone.
Yeah, there are theories. The main theory that's most commonly talked about is that obesity, high-fat intake diets are a risk factor for pancreatic cancer. Population, as you'll see tomorrow with Dr. Dudson and Chen's talk, is getting larger, and so the incidence of pancreatic cancer going up is paralleling the trend of obesity in the United States.
Yeah, I have a question. I just recently got a patient this week who is 30 years old with chronic pancreatitis from alcoholism, as well as recently diagnosed with HIV. And I'm kind of at a loss as to what therapies would be best for him when I know that some of the medications for his HIV are going to affect his pancreatitis as well as just his pain control.
Yeah, that's a tough situation. And you said the patient has acute pancreatitis, right?
Chronic.
Oh, chronic pancreatitis. Chronic pancreatitis. No booze. No booze. Have to completely abstain from alcohol first. Remove that insult.
He's 10 days sober.
Tell him to keep the streak going. It is, so remove that insult. Yes, many of the HIV medications can cause acute pancreatitis. One would hope that his chronic pancreatitis and/or acute pancreatitis that led to chronic pancreatitis was due to alcoholism. If he continues to have pain issues with the chronic pancreatitis and/or worsening pain with the HIV medications, then he should probably be seen at a high-volume pancreas center. Okay, thanks.
Thank you, Dr. Donahue.